Okay, so the first thing we're going to talk about is anaphylaxis, which is severe allergic reaction. Um, I know you guys are going to be basically be with the seizure student, but I just want you to be trained on it too, in case one day we need you to help. There are, our school does stock epinephrine pens up in each office to be given for severe allergic reactions. These are for kids that we don't necessarily know that they're allergic to anything. They've never been diagnosed. Maybe it's the first time that they've been stung by a bee or bit by some kind of bug, or maybe they ate something that they're not used to eating, and they present with life-threatening symptoms like mouth, tongue swelling, face swelling, difficulty breathing, hoarseness. That's when we would use one of the epinephrines that's stocked in our front offices. Otherwise, the kids that I know that have severe allergic reactions, their doctor has prescribed them EpiPens, which are kept locked in the front office drawers, labeled with the child's name and the correct dosage on them. So those are the two different kind of ways that EpiPens are either prescribed by the doctor or they're stocked by the Kern County Superintendent of Schools to be used if emergency use for a kid that doesn't have an EpiPen at school, because we just didn't know, parents didn't know that they were allergic to something. So I'm gonna share my screen with you, and we'll pull up the PowerPoint for anaphylaxis. And there is a little video to watch on the end of this. I hope the link works. The last time I tried to use it, the link wasn't working and I had to go to YouTube, so I hope it works today. So what is anaphylaxis? It happens when a person that has a severe allergy is exposed to an allergen. It causes problems with a person's circulation and breathing. The most common causes of food-related anaphylaxis are milk, eggs, peanuts, tree nuts, shellfish, wheat, soy, and fish. And our cafeterias are actually nut-free, so they don't serve anything with nuts in it. But we do have, some kids that may bring a lunch from home that has nut products in it. I always ask the teachers, if they're going to have a classroom party or something like that, that they ask the parents not to send any items with nuts in it, just because there are quite a few kids with nut allergies, to prevent them from being exposed to it. We have a couple kids that have such severe allergies that are on something called a 504, which is just like it's an accommodation plan for school to help with their disability. Maybe they have a separate area in the before it used to be the cafeteria, but now the kids aren't eating in the cafeteria, but they'd have a separate spot in the cafeteria where the kids aren't sitting directly close to them, and it's cleaned off with a special food sanitizing agent to help prevent the cross-contamination. So that would be an accommodation that's put in the 504. And another accommodation would be for like a trained aide or the nurse to go with the student on a field trip with the student's EpiPen and care plan. Every student that I know of that has a severe allergy has a care plan, like basically what to do if the student was exposed to the allergen. The only way to avoid an allergic reaction, of course, is to avoid the allergen. And we do have some people that can develop severe allergic reactions just by touching an allergen or smelling an allergen. This is just a little picture of what kids may look like if they start to have anaphylaxis. The face is swollen, the cheeks are swollen and red, and his lips are all swollen. They can have difficulty breathing. You may see a color change like turning blue, a wheezing cough, shortness of breath, hives or rash that's spreading over the body, swollen lips, face or tongue, and they're gonna have a hard time talking, and they can feel anxious or have a bad feeling of doom. And nausea, vomiting, and diarrhea is also a sign of allergic reaction. loss of consciousness, of course, or they feel like they're going to pass out, or that their heart's beating funny. Sometimes a kid may not be able to tell us exactly how they feel, but they'll just maybe say that they don't feel good and have these other symptoms. So EpiPens are an artificial form of adrenaline, and they're used for people who do have severe allergic reactions. They help treat anaphylaxis by reversing the symptoms. They must be given quickly during a severe allergic reaction, and we do not want to delay giving treatment. We want to give treatment as soon as possible. And whenever you give the EpiPen, you always get, it's an automatic 911 call. Even if the symptoms subside, the ambulance still needs to be called, because kids can have a rebound effect later on and the symptoms can return. So they need to go to the hospital to be treated. And then also, usually the EpiPens come in packs of 2s. So say you give the first dose of the EpiPen and the ambulance still hasn't gotten there, you can give a second dose 10 minutes later if the symptoms come back while we're waiting for the ambulance. There's 2 different doses of the EpiPen. One is the EpiPen, the regular dose, and the other one is the junior. The regular EpiPen is 0.3 milligrams and the junior is 0.15 milligrams, so it's half the dose. The difference is the regular dose of EpiPen is for children or adults that are greater than 66 pounds or more, and the EpiPen junior is for children 33 through 66 pounds. Children with identified severe allergic reaction will have the EpiPen in correct dosage prescribed by the doctors. Their doctor's orders, in order for them to have medication at school, they have to have a doctor's order on file. The orders are good from a year from the date they're written. The parents have to sign off saying too that they give permission for the school staff to administer any medication during the school day that is prescribed by the doctor. And it will be in a binder in the front office, and there will be a medication log as well to chart the medication on if it's given. And I'll show that to you, the medication information, in just a little bit. If we're treating a child that has an undiagnosed anaphylactic reaction, like I talked about, maybe it's a kid that we didn't know, and then they're having a problem breathing all of a sudden. Of course, we're not going to put them on the scale at that point and try to weigh them to give them the correct dose. Basically, we're just going to use our best judgment, eyeball them, and give them what we think they would need, the EpiPen or the EpiPen junior, based on their eyeballing their weight. It's better to overtreat than not treat at all. And that's, you guys can see the little picture of, and that's what our EpiPens look like in the office, the stock epinephrine pens. The yellow will be the regular dose, and then the green is the EpiPen junior. So steps in administering the EpiPen: we're going to locate the correct dose for the weight of the child. We're going to put on gloves, take off the cap, hold in our fingers and hold in our hand and wrap our fingers around the pen. We're going to have the student sit down. We don't want them standing up, we want them sitting down. And we're just going to locate the large muscle on the outer top of the thigh. You don't have to remove any clothing to give the EpiPen. It can be administered through jeans if needed. You're going to use a swinging motion and inject the EpiPen into the large muscle on the outer top of the thigh until you hear a click. When you hear the click, we want to leave the EpiPen in place for 10 seconds. Make sure that 911 is called. If you're giving an EpiPen, it's a good idea to have someone at the same time to be calling 911. And then, of course, we want to stay with the student and monitor them for additional signs and symptoms of allergic reaction. And when you guys, you're going to come in and do like a little hands-on with me, and I'll have you practice doing, I have fake like trainer EpiPens, you'll practice doing it. And this little video right now, it'll show you how to give it, because obviously me being on Zoom, it's not easy for me to show you. And then again, when you come into the office, I will show you in person as well. So we talked about if the child continues to show signs of anaphylaxis and EMS has not arrived, we can administer the second dose of the EpiPen or EpiPen junior after 10 minutes. So let me click on this link, and I hope it's going to work. We'll see if the sound works. I might have to do some adjustments. So. Can you guys hear it before I go on? No?
No.
Okay. All right, let me try to make an adjustment here and we'll see. I had originally shared my computer sound on the first Zoom, and then I don't think I clicked on it this time, so let's see if it'll work now.
Kids like me sound naps. Bigger kids sit or lie down.
Here's a spot, just hold my legs still. Press, click, and hold.
Be sure to hear the click.
Hold it there for 10 seconds. That's 10 seconds.
Always have an extra EpiPen ready because the medicine can wear off.
Then call 911.
Easy, white.
Today, doctors are seeing more and more children with allergies, especially food allergies. In a room of 20 kids, one or more of them will have allergies. While most allergic reactions result in merely uncomfortable symptoms, some anaphylactic reactions may be more serious and even life-threatening. About 150 children and young adults die from food allergies every year in the United States. Due to the unpredictable nature of allergic reactions, over 2.4 million epinephrine autoinjectors, such as this, are currently being prescribed. EpiPens deliver medicine quickly and effectively, but they only work if there is somebody around who knows where the pen is, when to use it, how to use it, and will actually do it. Times when you need to use an EpiPen can be stressful and may even be life-threatening. So it is important to have a plan of action so you can calmly react to the situation. Knowing when to use an EpiPen can be easy. If a child eats something they're allergic to, has hives, and is wheezing, give the shot. Sometimes, however, symptoms may not be as obvious. So if you are in doubt, always give the shot. You may not even have known what the child has eaten. But if you do suspect an allergic reaction, or a child is demonstrating 2 or more symptoms, don't wait. The longer you wait to administer an EpiPen, the harder it is to stop an allergic reaction, mild or severe. And allergic reactions can change from mild to fatal quickly. No child has ever died or has had serious problems from a standard dose of epinephrine. To protect the child in your life, be prepared. Memorize these steps and practice them. Review each child's action plan, know where each child's EpiPen is, locate it. Epi equals 911. If you get it, call it. Take the EpiPen out of its case. Hold it in a firm fist grip. Remove the cap. Make sure the child is sitting or lying down. Identify the big muscle in the thigh. Hold the leg and the child steadily. Press the orange part firmly against the thigh so that it clicks. Stay there. Don't bounce. Hold for 10 seconds. Press, click, and hold. Some of you may have an epinephrine injector that looks like this. This training device has yellow caps, but yours may have a different color. This has the same medicine as the EpiPen, the same kind of spring-loaded needle, and is used for exactly the same reasons. This injector has 2 safety caps. Hold the injector in a fist grip. Don't put your thumb on either end. Remove both safety caps. The red end is the action end. That's where the needle comes out. Remember, red to the leg. The red end should not touch anything else. Again, make sure the child is sitting or lying down and hold for 10 seconds. For this device, the needle will remain exposed after use. Please put it down carefully or put it back in the case. And if you haven't done so already, call 911. As with any emergency medication or device, please be familiar with it before you need to use it.
Okay, so I think that video shows it pretty good how to administer it. Now, there's been recent evidence-based practice research that shows that, you know, some people may panic after they give it to someone and not leave it in for the full 10 seconds. Research has shown that if it's left in for at least 3 seconds, it's still going to do what it needs to do, that the child will get all the medication. But we still want to try to keep it there for 10 seconds. But for some reason, if you don't, as long as it's in there for 3 minutes, they should still get the same benefit from it. And on that video, they showed what different ones may look like. The ones that we had seen earlier in the yellow and the green box, those are actually the brand name EpiPen. Other EpiPens may look something like these that are not the brand name. They still work the same. You take the cap off at the top and inject it exactly the same way. You just never want to put your fingers anywhere near the this part, the bottom part where the needle is going to come out of. If you do and you poke your finger into the small blood vessel areas, that you'll have to go to the hospital. So we don't want that to happen. So never put your finger by the end part where the needle comes out of. And then also we would give the EpiPen, the used EpiPen to the paramedic when they get there. If they don't want it, then I do have some sharps containers we can put it in. And I know they show recapping it. I would never recap it holding it in my hand like this. If I had to recap it, if it's one of the EpiPens where the needle's left exposed, I would put it down and push it into the cap. I would not hold it like this because that's you could hurt yourself too easily that way. EpiPens are kept at room temperature. They don't have to be kept in the fridge or anything like that. We want to make sure that we check the expiration date on it before we use it. And you see right there, there's this little window here where you can see the color of it. We want it to be clear, colorless. We don't want it to have little pieces in it or to be turning a weird color. And then the expiration date is also on it as well right there. So EpiPens should accompany your students on field trips with a trained person. And then I talked about how students with EpiPen may need additional accommodations or a 504 plan. So as a school nurse, I do those, and we hold meetings yearly with the parent and the teacher and like the principal or the vice principal to go over the child's 504 plan. If you do ever go on a field trip with a kid with an EpiPen, their care plan will go with them. In each school office, for all the kids that I know have a medical problem, I have care plans in there for them. So the care plan, if you ever have any doubts, you look at what's written on the care plan and the doctor's orders. And that's it. Do you guys have any questions about this stuff so far? No? Okay. I think the next thing I'll show you, just because we're talking about giving medication, is the medication administration procedures. And then after that, we'll go into seizures, since that's your student's problem is the seizure. So we'll go into that. But I just want to go ahead and show you the medication information first. Okay. So the parents are, whenever a child needs medication to be given during school hours, the parents are responsible for providing the signed doctor orders to the school. And the orders are written from one date, or valid, sorry, from one date, or 1 year from the date they are written. The parent has to bring the medication to and from school. And once they bring it here, we leave it locked up in a drawer. But at the end of the school year, they're supposed to come and pick it up. We need the parent to provide the medication in their original properly labeled medication containers from the pharmacy. I just don't want the parents to send the medication in like a Ziploc bag or something. It has to have all the proper identification on it. The medication needs to be provided in the form it is to be delivered. So if the doctor's orders write that the medication is a liquid, it needs to be given to us in the form of a liquid and not a pill. Upon arrival, all medication is to be counted by the parent and the designated trainee or school staff. And the staff is to document the medication received on the appropriate forms. And I'll show you guys that form in just a couple minutes. Our parents are notified annually through the district handbook about our school's medication administration policy for the students. It is in there, but I don't think a lot of the parents read it because a lot of times they have no idea of what it is. Medication is administered to students by licensed health professional. That would be myself or Lori, or it may also be one of the LVNs that we have. And then also it can be administered by a non-health professional who has successfully completed a school administration in service with documentation of training, supervision, and monitoring updates. So every year, I always review this information with the health aides, the other nurses, and then the school administration, like the principals, the vice principals, and also our office secretaries, because usually it's our office secretaries who are giving the meds that are scheduled on a daily basis, like pills. So our medication is administered with doctor's orders, parents' written permission. I already talked about the proper medication labeling, original medication container with student's name, name of doctor, name of pharmacy, medication name, dosage, and time it should be given. We want to maintain confidentiality of our students, and the medication is to be stored and kept in a locked cabinet or drawer. We need to document that we receive the medication and record whenever we give it, and that the school needs to have emergency policies and procedures in place for injections. Like I just talked about, if a child was to have a severe allergic reaction, we do have the stock EpiPens. And then also I have stuff for insulin reactions for diabetics that are having a low blood sugar. And we'll go over a little bit about diabetes, not too much. It will be either Lori or I or one of the LVNs administering insulin to any of our diabetics. But there may be a time in the front office where the student comes in and they feel like they have a low and they can get treated with a juice. So I'll review that in just a little bit too. Whenever we give medication, we always want to make sure that we wash our hands or use the hand sanitizer and wear gloves before we give it to the student. And the student should be doing the same thing. They should be washing their hands or using the hand sanitizer before they touch any pills. Especially now with COVID, we need to make sure that we keep things as clean and germ-free as possible. So in nursing school, we're always taught the 6 rights of medication administration. So we need to make sure that these 6 rights are correct, that we're following these 6 rights to make sure that we don't have a medication error, which would be, of course, the right student. We want to make sure we're giving the right student the right medication at the right time by the right route, which the doctor will write on there. It'll say or PO, which means orally, or if it's an injection like an EpiPen or insulin, it is an injection. And we want to make sure we have the right dose, that we're not giving the child too much or too little, that it's the correct amount per the doctor's orders, and that we're doing the right documentation, which includes the student's name on the form, the medication, the dose, the route, the date, the person who administered the medication, and any unusual circumstances. Like maybe the student's scheduled to come in every day at noon for like an ADHD pill, and they just didn't show up for their medication, or maybe they refused to take it, or there was a time lapse in the medication administration. Like I've had a student come in that was supposed to come in before, and they showed up, they totally forgot, and the teacher got busy and forgot to send them up, and the medication was given an hour late. That would need to be documented, and the parent should be called and made aware, you know, the medication was given an hour late. Sorry, this happened at school. There is a separate form to fill out a medication error as well, which I'll go over. So I'll show you the medication form, and you'll see the different codes you can put in, like maybe the student's refusing to take it or they were absent from school that day. or just didn't come to the office to take it. So there are rules and guidelines related to medication administration in California schools, which is the California Ed Code section 49423. And it's basically stating that all these things have to be met in order for the school to administer the medication, which we talked about. Requirements for new orders. So the requirements are the student would need new orders if the orders are over a year old, or if the student's medication changed in any way, including the dose, time, or type of medication, we would need parents to provide new orders. We have a lot of kids in our district with inhalers. So I do have 2 little videos to show how to use an inhaler correctly, either with a spacer or without a spacer. The spacer is the preferred method because it delivers the medication more accurately and consistently. But I can tell you this, a lot of the parents do not send the spacer to school, so most of our kids use it without the spacer. But a lot of times the kids will want to just rush through the puffs and not do it correctly. So that's why I have these little videos on here, which I'll show you.
Metered dose inhalers, which are commonly called puffers or inhalers, spray the medicine out so that you can breathe it deep into the lungs. Inhalers deliver medicine very quickly. Inhalers are compact and light, so they can be easily taken with you wherever you go. It's very important to use your inhaler the correct way to make sure the medicine gets deposited into the lungs, where it works the best. Incorrect technique can leave some of the particles from the medicine on your tongue or throat, where it won't help at all. A spacer or holding chamber is an attachment that should always be used with your inhaler. The spacer holds the medicine in place so you can breathe it in easier. Now, let's demonstrate how to correctly use a spacer and mouthpiece. First, remove the cap from the bottom of your inhaler. When you get your new inhaler from the pharmacy, you need to prime or waste it by spraying the medicine into the air 4 times. Now, fit your inhaler into the opening at the end of the spacer. Shake the inhaler well for 10 seconds. Turn your head to the side and breathe out. Close mouth around mouthpiece of spacer. Push down on the inhaler once. Now the medicine is inside the spacer. Right away, take a slow, deep breath. The goal is not to hear a whistling sound. If you do, this means that you're breathing in too fast. Hold your breath for a count of 10. Now slowly breathe out. Rinse your mouth out with water or brush teeth or get a drink after using controller medicines, such as inhaled steroids. Many times, the correct dose of your medicine will be to inhale 2 puffs. If this is what is prescribed for you, then wait 1 minute after the first puff and then follow all of the steps again. Remember, if you have questions, call your doctor's office, asthma care team, or pharmacy.
Inhaled medications are essential for preventing and treating asthma attacks, but the medicine is only effective when you use your inhaler correctly. Without proper use, your inhaler may not deliver enough medication to your lungs to control your symptoms. To properly use your inhaler, follow these simple steps. First, take off the cap of your inhaler and remove any lint or objects in the opening. Shake your inhaler for 2 to 5 seconds. Remember, if it has not been used for more than 48 hours, you must prime your inhaler. To prime your inhaler, depress the canister once. This ensures the next dose will deliver the correct amount of medication. Next, sit up straight or stand up. Breathe out all the way. Tilt your inhaler slightly and put it into your mouth with your lips sealed around the mouthpiece. As you begin to slowly breathe in, depress the canister. Remember, in order to deliver the medication into your lungs, it is important to start breathing in before depressing the canister. Continue to slowly breathe in over 3 to 5 seconds until your lungs are full. Hold your breath for 10 seconds, or as long as you can. If you need to take a second puff of your inhaler, wait 1 full minute between puffs. You should rinse your mouth out with water after using your controller or inhaled steroid inhaler. Be sure to spit out the water after you're done rinsing your mouth. Recap the inhaler for storage. And that's how you properly use an inhaler to treat or prevent asthma attacks. Your doctor can work with you to make sure your medication is working, and your healthcare provider is the best source of information for any questions and concerns related to your condition. For additional help, information, and resources, visit www.health.utah.gov/asthma.
Okay, any questions about the medication stuff? You guys can always email me or call me to, what's that, Myra?
For the spacer, like, is anybody allowed to use it or just like little kids?
I think really probably anybody would be allowed to use it, but I think it makes it easier for the little kids to get more of the medication. You'll notice a lot of times our kids, they won't like hold their breath for the 10 seconds and then they'll go right for the next puff instead of waiting for a minute in between the puffs. They kind of just rush through it because I don't think when the doctors prescribe these inhalers, I don't think they really give the kids a very good education, or the parent, on how to administer it. They just, it comes from the pharmacy and they read the directions and just think 1, 2, and that's it, instead of holding the breath. So we honestly, I think we only have one spacer here, and then I think maybe one that's down the end. The parents usually don't send the spacers. It's usually just the inhaler. Our kids, we do have quite a bit of kids with asthma, and some of them may come in, they have orders to use it before PE or before going out to recess. So we do, asthma is a big thing, but I haven't had to ever call the ambulance for an asthma attack yet. Usually it seems like the inhaler works pretty well. All our kids that I know of that have asthma will have a care plan up in the office too. Some of our students may have orders to carry the inhaler. They have to have specific paperwork filled out that the doctor says they've been trained and that they're responsible, and that the school can take that privilege away at any time if they're using it incorrectly. But those orders are usually reserved for older kids in like junior high, not the little ones. I had a dad last year and the year before, the kid was really little, only in 2nd grade, and the doctor did write orders for him to use carry the inhaler. But honestly, I had talked to the dad and I didn't feel that was a good idea. So the plan was the kid would come to the office to be monitored to make sure, that symptoms had resolved and that it was used properly. That was only to be used if it was a true emergency. I see, Anya, your hand was up.
The 504 plans, that's what the form is called.
Yeah.
Are they only used for trips, or is it just the whole general plan for the child at school and for the field trips?
Yep, exactly. It's the whole general plan for any accommodation for the student and their disability.
Oh, so it's overall?
Yeah, overall. Sometimes it'll be like having bathroom breaks or having a lesson retaught if they missed, or, just it's overall. But usually if the kid does have a 504 and they have meds, that's included in there for the meds to go on the field trip with a trained person.
And you said
and
you were going to show us.
Yeah, I'll show you what one looks like. I have about 20 504s between all 4 schools. I will show you what one looks like, and there are copies in each office for those kids in the medical binder that have the 504s. And they all have, the kids that have care plan, or the kids that have 504s have a care plan too that goes along with the 504. But I do have some kids that just have care plans and no 504s because their disability really doesn't affect their school day. Like maybe a kid just with asthma, mild asthma, and they have the symptom, the asthma inhaler up in the office. They don't need a 504 for that. It's more kids that need more accommodations than just, normal.
Because when you started talking about the form, I was already thinking about a bunch of questions like, is it like really to the point, like down to the detail? Like
Yes.
when it comes to like certain situations, like a water park and I don't know, other.
Oh,
like,
no.
That's what I was thinking. Like, how does that work? Like,
yeah.
when it comes to certain like field trips and all that.
No, it's not that detailed, but I will show you. I will show you an example when you come in to do your hands-on, and we'll do the EpiPen too. And that way, and you'll see an example of the care plan and what the doctor's orders look like. That way you can familiarize yourself. And then the day you come into, I will take you up to the office. I'll show you where the stock epinephrine pens are for this campus for BE. And also I will show you where your student's backpack is, and that has his medication in and his binder. It has the care plan in there and his binder and the orders and everything to review.
Okay, that's good.
Okay, let's go on to the medication. I'm going to show you the different medication forms, and then we'll probably take a quick break, and then we'll move on to the seizure stuff. Okay, so this is what the form looks like that all the front offices have when we have a student's parent bring in orders for medication at school. So it'll have the student's name on it, the date of birth, whatever school they're attending, their teacher, whoever their doctor is, what their health condition or diagnosis is, if it's asthma or ADHD or maybe diabetes, it would be on there, and the type of medication that's going to be given, the dose, and the time to be given. So this is like a whole month's worth of charting here. So we would just put, whenever the kid comes in, we would put what date it is, the time, and then our initials. And then here under code and comments, I'm going to scroll down. You can see the code reason. Most of the time it's going to be G, that the medication is given, or if it is the student refused, we would put an R and the parents notified, or if they were absent, we could put A. And then once you initial here, you don't have to keep, you can sign once. You don't have to keep signing down here every time you give it. You just have to sign once and init, but you do have to initial every time you give it, if that makes sense. So that's that form. Here is our medication error form. Like I talked about, for some reason, if we made a mistake when we gave the medication, this would be filled out. Just the demographic information about the student, the date the medication error occurred, and the time, and the person that was giving the medication. And then you can describe what happened right here. Parent, guardian notified. I always want the parent or guardian notified. And then we would check here how notified. And then any comments, and then sign and date it here. We do have some parents who won't answer the phone. Maybe they're at work or something else is going on, or their phone number changed and we don't have the most recent phone number for them. So in that case, I would want to send it in the mail and send a copy home with the student. So we would check off sent in the mail and then put comment, form sent home with student in their backpack, and teacher notified. Sometimes teachers can, they have different ways of getting a hold of the parents through their little apps like Class Dojo or whatever they use that the parent may respond to. So at least we have documentation that we tried to get in touch with the parent. And then I'm going to show you the field trip medication log. So if you did go on a field trip with the student, you would put what school the student goes to, where the field trip is, and the date. And then here you would write the date, the student's name, what medication, and the time. And then also who checked it out. So if you're the one checking it out, you would sign here that you checked it out. And then when you come back to campus and you're putting the medication away, you would do the same thing, put the time that you're checking it back in, sign it. Now, if you had to give the medication, this is just your place to chart it for that time period while you're out on the field trip. Myra, it's saying that you're in the waiting room.
Yeah, I was gonna wait until you're done talking. It's I'm on my laptop, but it's dying, so I wanted to see if I can get on through something else.
Okay, so you want me to admit you then? Okay,
Yeah,
I'll
please.
admit you.
Thank you. Then I'll leave from this one. Okay.
All right. So I'm gonna close. Actually, I'll pick up the seizure stuff. So if you guys want to take like a 5-minute break and come back, we'll do that, and then we'll go over the seizure information. Okay.
Okay.
All right, ladies, I'm just going to mute myself and take a quick potty break. I'll be right back.
Okay.
Okay, I see both of you are back. So we'll go over the seizure stuff, and then there's like at the end of the PowerPoint, it's like a 19 minute long video I'll show you guys. It shows you the different type of seizures, what they may look like. Because all this stuff is kind of confusing. I don't expect you guys to know the names of all these different kind of seizures, but just to be able to recognize if one's happening. So a seizure, it's just a sudden, brief disruption of the normal functioning of the neurons in the brain. If to have an epilepsy diagnosis, there has to be recurrent seizures, 2 or more, which are not provoked by systemic or acute neurological insult. So it's going on not because maybe like there's a fever or an infection, there's something else going on, or not sometimes people with diabetes, if their blood sugar gets too low, it can cause a seizure. So it can't be caused by something like that. And the 2 different classifications of seizures are partial and generalized. Partial, there can be simple, complex, partial, secondarily generalized, and then generalized, there's absence, myoclonic, atonic, tonic, and tonic-clonic. Like I said, there's a whole bunch of different kinds, so I don't expect you to remember the names, just what they might look like. So a complex partial seizure is an epileptic seizure that it's associated with unilateral, so one side of the cerebral hemisphere involvement, and causes impairment of consciousness. It also occurs in all age groups. Between 8% and 31% of children who have epilepsy have the complex partial seizures. Complex partial seizures, again, continued. These are some things that you will notice. Their awareness is impaired. They can't respond to you. It can begin with a blank dazed stare. They can have automatisms, which are repetitive, purposeless movements, clumsy or disoriented movements, aimless walking, picking things up. They're not talking clearly, or they're lip smacking. It may look like they're chewing on a piece of gum. They can last 1 to 3 minutes. They're followed by tiredness, headache, or nausea, and the person can become combative if you try to restrain them, or it also can be confused with drunkenness or drug abuse or aggressive behavior. So the complex partial seizures, they typically involve automatic behaviors, the automatism, which include like they're going like this, picking at clothing, lip smacking, wandering. They can have an aura that can precede the seizure, and they usually begin before age 18, and the most common type of seizure in teens and adults. And this type of seizure can progress to a generalized tonic-clonic seizure, which is the classic seizure we think of with the shaking and the jerking. So if one of these seizures lasts too long, it can progress into the tonic-clonic. So the cause, many times they don't have a known cause in a lot of cases. There might be a brain lesion, congenital development anomalies, trauma, or brain tumors. Like say somebody has a head injury, can be a trauma that can cause it. And again, these are just the different type of things you may see: sensory, dizziness, unpleasant smell, unpleasant taste. They can have hearing problems, hallucination during it. It's affecting their senses. The autonomic and motor things you may notice: mouth movements, picking at clothing, blood pressure changing, or maybe they have a loss of bowel or bladder control. And behavioral, it can cause rage, anxiety. The person may cry, be confused, or they seem like they're dreamlike state, or they may be actually yelling or shouting. So in the school setting, we just want to make sure that, of course, that our staff is trained for what to do if there is a seizure, know how to respond. And I do have seizure care plans for all the students that I know of that have seizures. The MOT and the bus driver will get a copy of their seizure care plan. And then you guys would be the trained staff on campus to help your student if he does have a seizure. And your child, the student that you're going to be working with, he does not have a 504. He's on a IEP, so you can't have both an IEP or a 504. So his accommodations for his medical problems are included in his IEP. And here is our video. I hope it will work. Here we go. And this is kind of old, but it is a good video to watch because it does help you to see the way the different seizures can present.
America in the 21st century is a picture of diversity. So too are our schools. Not only ethnic, economic, and intellectual diversity, but also physical and psychological diversity. Since the passage of the Americans with Disabilities Act in 1990, America's schools now do a better job than ever of educating all children. It is the right thing to do, yet it is not without challenges.
Do you see anything there that...
How do our educators learn about the variety of medical conditions before them? The Epilepsy Foundation has made this video to help you learn about seizures in school.
I had a stroke in utero, which caused a brain injury. The brain injury caused my epilepsy.
Next thing I know, eyes roll in the back of the head, and he just collapses in my arms, and he starts shaking.
And in the fall, I hit my head on the granite and then on the hardwood floors.
It was just scary. It was a moment of panic. What do I do?
When would it happen? Where would it happen again?
You worry about your kids, you know? You don't want them to be hurt, so you think about it a lot.
It's much more common than most people appreciate. Somewhere around 1 out of every 100 people in the United States has epilepsy right now. And somewhere between 3 and 5% of the population has had a seizure at some point in their lives.
Some people call epilepsy or seizures a brainstorm, a storm in the brain. But what does that mean? Well, it means that this normal activity where the cells are signaling from one to the next is basically doing it in an uncontrolled way. So it keeps going and going and going. Depending where in the brain that activity happens, your seizure looks different. It could be a repetitive thought, it could be a vision, it could be a smell.
It can also be the classic thing that people tend to think of when they're thinking of seizures, and that's the tonic-clonic seizure, or what we used to call the grand mal. It can also be, on the other side of the coin, what we used to call petit mal, where all we're seeing is an absence of a person. They just go blank for a moment, stare off, maybe a little bit of movement. And so we have the huge range from the biggest, the strongest, the most worrisome for most people, the grand mal or the tonic-clonic, all the way down to a little bit of movement or simply staring.
More than 300,000 students in the U.S. live with epilepsy. Working in the school system, chances are you'll encounter a student having a seizure.
When he started school was the biggest fear of my whole entire life, not knowing when you were going to get that call.
And then she started having a seizure. We were pretty scared. So I sent some students down to the security office. I sent another student to another room to hit someone else's security button, and I tried to call the clinic. The clinic went directly to voicemail.
Attempting to get help is the right thing to do, but how can a teacher assist while waiting for help to arrive?
The first thing they should do is make the child safe. And so that involves making sure there isn't something near the child's head in particular, okay, that could produce some danger.
The next thing you do, if the person has glasses on, you want to take them off. loosen their clothing. If you can ease them to the ground, allow them to go to the ground, and then turn them on their side.
It's helpful to do that because what's often happening, and it makes people very scared, is that you hear guttural sounds, as though they're having trouble breathing. And so what you're trying to do is to allow the head to turn to the side so the saliva, okay, which the person isn't able to swallow at that time, can come out of the mouth.
You will want to get help. In the school rooms, they have buttons that you can push to get help. You can ask someone else to go get help. Call the health room. And if this is someone that's known to have seizures, they'll come with an individualized care plan, which will say if this person has medications or not.
Things not to do are to either put something in someone's mouth or think that they're going to swallow their tongue. The tongue is actually attached to some pretty big muscles in the throat. And so while patients may bite their tongues, they aren't going to swallow them. The more dangerous thing is that if you put something in someone's mouth that's rigid, they may crack a tooth. If it's something that's soft and they could potentially bite off, then the part that they bite off may actually be aspirated or go into their lungs.
Safety, clear the environment, roll them to their side, and then just stay with them and allow it to run its course. There is nothing that a person can do to change the course of that seizure.
A tonic-clonic seizure is not usually dangerous to the individual, but there are a number of points to consider when deciding whether emergency medical services should be called or whether the student should be transported to the hospital. Medical services should always be called for students having a first-time seizure. EMS should also be called under any of these conditions. The student is injured or has badly bumped his or her head. The seizure happened in water. The convulsive portion of the seizure lasts longer than 5 minutes. A second seizure begins shortly after the first concludes. The person does not regain consciousness within 5 to 10 minutes, or the person has diabetes or is pregnant. But if a student who is diagnosed with epilepsy has a brief seizure and has not injured him or herself, calling EMS may not be necessary.
When you know that someone has a seizure disorder, and someone has a seizure in your presence, whether it's a generalized tonic-clonic seizure or a different type of a seizure, generally speaking, you do not need to call 911 or rescue services unless the seizure is going on for more than 5 minutes.
When calculating the time, keep in mind there's always a period following the convulsions where the person is unconscious or extremely groggy. This is known as the postictal stage, and this time period is not included in the 5-minute calculation.
You may see somebody being very sleepy, really poorly, slowly responsive, and that would be described as the postictal stage. The seizure is over, and that's an important thing for people to understand, because the postictal period may go on for quite some time, for many minutes, even 15 minutes, 30 minutes. And in that time frame, that's not the seizure. So that doesn't mean, hello, the seizure is going on and you need to call medical services. You need to be there reorienting the individual, calming them, saying you know what happened and that they're going to be right back up and doing things shortly.
It's not something people need to freak out about, because chances are that person's had a lot of seizures before and they've bounced back every time.
Another common form of seizure that is not nearly as obvious is the complex partial seizure. Because only a small part of the brain is affected, a person may still be able to perform gross motor skills like walking or sitting upright, yet be totally unaware of his or her actions. They may stare, mumble, repeat phrases, blink excessively, smack their lips, or pick at their clothing. However, they will be totally unresponsive to instructions because their consciousness is severely impaired.
Let's say somebody were speaking to me. I might remember none of it,
Kevin,
a little part of it,
Kevin,
or it might be all jumbled together.
Kevin, can you hear me? Can you hear me?
It can look like something else. It can look like a student's not paying attention. It may look like a student is using substances they're not supposed to be using.
I think it's important that a teacher not assume that the student is simply not paying attention or is, daydreaming, that they understand that it is possible to have these more subtle forms of a seizure.
where the mind sort of just checks out for a few minutes.
Their consciousness is impaired. It's not lost, but they're clearly not processing language, and they're not processing your intention. So that what you want to do is take harm out of their way, close the door. They will take the path of least resistance.
But a perception of being threatened will lead to somebody pushing away, hitting, fending off what, at least momentarily, as a reaction, is thought of a threatening move.
So that I think the most that you would want to do is guide. You don't want to restrict them. You don't want to force them to sit down. That is the last thing you want to do.
A complex partial seizure can last from 1 to 5 minutes. When it's over, the person may be tired or may recover immediately. Emergency medical services do not need to be called if a person who is diagnosed with epilepsy experiences a complex partial seizure, unless they're not fully recovered within 30 minutes. There are 2 additional forms of seizures school staff should be aware of: simple partial and absence. When a person has a simple partial seizure, their consciousness is not affected because the abnormal brain activity is occurring only in one specific area of the brain.
My arm is jerking. I can't stop it. It's not in my control. Brain that corresponds to that, the opposite side of the brain, and the motor area of the brain is making this happen, but it's uncontrolled, and that's a seizure.
Absence seizures, on the other hand, do affect consciousness and can easily be misinterpreted as daydreaming or ADHD in kids.
Were they just blank staring spells? Maybe, with some eye blinks. But again, just little thing. The complex partial, there's more confusion after it. The absence, right back.
And when a person has an absence seizure, it's like a switch going on and off, okay? They're with you one moment, they're gone for a few seconds, and they're right back with you, picking up right where they left off.
No special action is required if a student who is diagnosed with epilepsy experiences an absence seizure, except to make sure the student did not miss something important being taught at the time. However, if you witness repeated episodes that you suspect may be absence seizures and the student is not known to have epilepsy, parents or guardians should be informed. So epilepsy can come in many forms. On one end of the spectrum are extremely brief absence seizures that may occur multiple times a day. On the other end of the spectrum, tonic-clonic seizures that may occur only rarely, but when they do, can be traumatic for the individual.
I ended up having a seizure in the hallway, and it was bad because then classes changed and everyone saw me having a seizure.
People are still ashamed of it. You know, diabetics have come out and they've been more comfortable with it. And epilepsy is still one of those things, you just sort of keep it in the closet. You don't want to come out and wear that sign that says, I have epilepsy.
With my son having it, he's kind of outcast. They think, oh, he's got seizures, you know, at this age, they're going out for sleepovers. My son, nobody ever asked him for fear that if they would have one, that I would hold them responsible.
Yeah, I feel sad when they call me names.
I have to sit out for gym sometimes, and that makes me feel uncomfortable. And people look at me like, what's wrong with you? Why are you sitting out? So I have to tell a few people, and it hurts because they'll spread it around. And last year I didn't have any friends in gym.
To have to wear something like that out on your shirt sleeve, so to speak, it's got to be, you know, a very difficult, cross to bear. So I think that as much as we can do to support students, make them realize that, school is a supportive place, and we'll be there for you when these things happen and after they happen.
I think it's important for the teacher and the administration to set a tone in the school setting of acceptance. Epilepsy in students is just part of their individuality.
Any type of bullying or teasing, and that could be, making a funny look or, any
anything verbal or aggressive in nature. And if it is seen, then there are going to be consequences, and the teachers need to call it out right then and there. That's bullying, and that will not be tolerated.
I think the most important thing is to stress to kids that when they come back to the classroom, the student that had the seizure may feel a little uncomfortable about it, and just to make them feel like they're still a part of the classroom. If you're a good friend of theirs, obviously you want to make them feel comfortable and welcome back.
Afterwards, I think the best thing to talk about is that the fact that this is not a condition of where the child is violent or crazy or insane. Nothing like that at all. In other words, it's a condition which is just an electrical storm in the brain that creates, reflexes in the body that can't be controlled.
And all of my friends were really supportive, and I think from that point on is when I became more open about having epilepsy and, sharing what it's like and all that kind of stuff with my friends.
School staff should also be aware that some children with epilepsy have additional emotional and psychological challenges.
Many people, a number of people with epilepsy, besides the seizures, have depression. They may have learning disabilities as kids. They may have behavior problems such as ADHD or inattention.
Like my son has a lot of the hyperness and attention problems. So they need to be aware that that goes along with it. So don't reprimand the child. You're going to have a child that you're going to have to repeat things to. And my son has a 504 plan in the school. So, they have to repeat directions. They have to tell him the directions for an assignment before they hand him the piece of paper, because if not, they hand it to him. He's not going to listen. So there's things that a school can do to make the day go by a lot smoother for the child, and be aware that special things need to be done.
In many cases, however, students with epilepsy do not have learning disabilities, and a supportive school system can ensure that students with epilepsy thrive in every way that kids do.
I think one of the things the school system has to help in, people's friends have to help in, families have to help create, is a situation that says 99.9% of the time your brain's fine. There's nothing wrong, okay? You can do anything you want to do. And I think in knowing that and in understanding that, I think we wind up with young people who grow up to be everything that they were meant to be.
Children with epilepsy should be able to participate in most school activities. They should be able to go on field trips, they should be able to engage in extracurricular activities, and they certainly should be able to engage in sports.
Sports are my way of not necessarily fighting back, but not letting epilepsy set me back.
At school, Jake had a seizure in PE and the kids caught him before he hit the ground. That's what it's all about. It's all about people, knowledge is empowering and it'll protect all of us. So keep talking about it. I'm right there with you. I'm not going to stop fighting forever.
I am not different than any other kid.
Epilepsy, schmepilepsy. That's the way you should look at it.
Don't start treating me differently. I'm just the same person with a minor addition.
For more information on seizure recognition, treatment, and epilepsy, visit epilepsyfoundation.org or call 1-800-332-1000.
Okay, so seizures are diagnosed through CT scans of the brain, EEG that shows slow waves or spikes, MRI can be helped to determine too, and it shows detailed images of the brain, blood test and lumbar puncture. This is information about diastat. A couple kids in the past, and the student you're going to be working with did have diastat as an emergency rescue medication to be given for a seizure, but your student no longer has orders for diastat. Your student that you're going to be working with has orders for a different medication. The diastat is given rectally So it was kind of harder to give in an emergency situation. And also you really have to respect the student's privacy. But the medication now that if with the student that you're going to be working with, it's a medication that's given in the cheek, in between the gum and the cheek. It's called a buccal administration. So you would just pull the cheek open, drop it down in there, and you just rub it on the outside for a few seconds and let it dissolve. A side effect of any rescue seizure medication is going to be central nervous system depression. So that's why I'm going to train you guys on CPR, because even though it doesn't happen often, it is a possibility that the child can stop breathing because the central nervous system has been depressed too much. So I will do CPR with you guys tomorrow. But with the diastat, it is a rectal medication. It comes in a syringe. We're not going to go over how to use it because most kids now, they are getting oral medications, like I said, the buccal medication, and they're going away from the diastat, which I'm kind of glad about. We had a student a couple years ago who had such bad seizures. The diastat, he was on diastat and it had to be given in the cafeteria. They had to clear all the kids out of the cafeteria before it was given. And two, if you're in a classroom and the student is having a seizure, the teacher really needs to be clearing the rest of the kids in the classroom out just to provide privacy for that student. And I'm going to go over with you guys in person your student's care plan. And if I use this training for additional people, I don't want the student's private information to go to someone who doesn't need to see it. So I'm going to do that in person with you guys. So emergency medication, and the student you're going to be working with, that's the clonazepam, or it's also called Klonopin. So, and that's the oral disintegrating tablet, which I'll show you guys how to do it. So with giving this medication, like I said, you have to monitor for respiratory depression, and we want to give the medication according to the doctor's orders. Some students' orders may say 5 minutes or longer, 3 minutes or longer of a seizure. Your students' orders say at the onset of a seizure. And obviously, as soon as you notice it, I mean, it's going to take a minute to get the stuff out of the medication out of the bag and administer it. So there's going to be a little bit of time lapse. Of course, we want to follow the 6 rights of the medication, like I talked about earlier. Make sure it's the right student, the right medication, the right dose, the right route, the right time, and the right documentation. So this is just medication administration schools position statement from the National Association of School Nurses. I'm not going to go over that with you guys. And this is just concerns about giving diastat in school. Of course, we talked about the risk for respiratory depression, when to exactly administer the medication if needed. With any medications, it's going to say on the seizure action plan how many minutes the doctor wants it to be given. And we want to make sure that we have a trained person, the nurse or the trained staff, to give the medication. Prevention of seizures. The student should be getting regular sleep, have stress management and relaxation techniques, avoid drugs and alcohol. They want to take all their medication prescribed by their doctor. Students that have epilepsy, they're usually on a maintenance dose of seizure medication they take every day just to help prevent a seizure from occurring. And we want to make sure that they're eating a healthy diet. This is what a seizure action plan can look like. Your student did have one filled out for him by his doctor, and it also lists at the bottom here the medication and when to be given, and then emergency care, which the video went over. Of course, we want to stay with the student. We want to time the seizure, protect them from any injury. We want to lay them on their side if we can to prevent choking. And we want to monitor for breathing, give the medication as ordered by the doctor. And we want to call for your student. You're going to be calling, or someone else, if you're giving the medication, the teacher or someone else can be calling 911 while you're getting the medication. So for your student, 911 is to be called at the onset of the seizure too. Whenever you're getting ready to give the med, someone else needs to be calling 911 for the student. And this just goes over the first aid for seizure. Recognize the common symptoms, which we went over: blank staring, chewing, fumbling, wandering, shaking, confused speech. We're going to follow these things: time, speak calmly, don't grab or hold. We want to make sure really that the other kids, that they get removed from the classroom. And then when they do come back, I've had to talk to a classroom before that's witnessed a seizure, not at this campus, but another one, because the kids were scared and confused. They kind of didn't know what happened. Block hazards, so we don't want someone to get hurt during a seizure. And anytime a child does have a seizure and they are injured, we want to call 911. So if they hit their head badly, we still want to call 911. And also too, if it's a diabetic that has a seizure, and there's other things we would be doing, that 911 needs to be called as well. Diabetics, when they're having a seizure, they can't have anybody when they're having a seizure obviously can't have anything in their mouth. But with diabetics, the reason why they're having a seizure is usually because their blood sugar is so low. So again, this is what a seizure action plan can look like. Okay. Any questions over the seizure stuff you've seen? And we'll go over some stuff again, like I said, the medication that your student gets and the care plan when you come in to see me. So we'll go over all that again. There's a couple more things we have to get through before I end this at noon. So I want to get through that with you. You guys both, were you able to view that link for the COVID training that I sent you?
Yes. Yeah,
Okay,
is this the one that you we did?
If you were here at the beginning of the school year, yes, it's the same thing. But I know if people were just hired, I haven't redone it with the new hires, so I didn't know if you guys had done it already, so I sent you the link just in case. So here's the seizure action plan up close. The other one on the PowerPoint you couldn't see very well, but it looks just like this. And it says, the name, address of the student, emergency contact, what type of seizure they have, generally how long it lasts and how often it occurs, what happens, and then how to respond to a seizure. All these things we already talked about. First aid, stay safe, turn them to their side, stay with them, give the rescue medication according to their emergency action plan. We want to notify emergency contact, call 911 for your student at the onset of a seizure. And all these things we talked about, we're going to stay with, follow. Your student doesn't have a vagal nerve stimulator, so you don't have to worry about that. He's actually never had a seizure at school. He's pretty stable, but it's part of his education plan right now that he has an aid, and he will need somebody to go with him to the bathroom, not in the stall or anything, but just waiting outside the door just to make sure that he doesn't have a seizure, that he's okay.
Yeah, that was going to be one of my questions.
Yeah.
Oh, wait,
so anytime he would have recess or something too, you don't have to stay right next to him, but just watch him to make sure he looks like he's fine.
Like we have to, okay, so you said we have to go to the restroom with them, obviously not in the stall.
Yeah.
Because I know if there wasn't COVID, the other kids are still allowed to go in, right?
Mm-hmm.
Or would they have to wait?
If it wasn't COVID, anybody could go in and use it. But right now, the kids aren't supposed to be really using the restroom at the same time as other cohorts, because they're supposed to, stay with their class.
Yeah, because I saw how they have like the 2 rings, like more or less like only 2 kids like in the restrooms. But yeah. I know I kept asking some people around, like just kind of just like general, because I know they're not going to answer it like precisely like what you're saying right now. I was like, what about the restroom? But yeah, you answered it.
And MOT is cleaning the restrooms very frequently, or, disinfecting the restrooms very frequently. I know our plan is, to try to not have kids in there at the same time. And of course, not the cohorts mixing in the bathroom, especially. But now that the kids are coming back, it's probably presenting more of a challenge. Our special ed kids were just that, when our special ed kids were just on campus, it was a lot easier. The teachers would just coordinate a bathroom schedule. Now we have the K through 3rd back, and the next week it's 4th through 6th. So I'm sure it's gonna be a little bit more difficult as more kids come back. And then also sometimes, I don't remember if the video talked about this, I think it does, kids can have what's called like cluster seizures, where say they have a seizure, the seizure stops, they don't regain full consciousness yet, but then another seizure starts. So of course, if that's going on, 911 needs to be called.
Oh yeah, I did mention that in the video.
Yeah. And some of our kids, they don't have rescue medication at school at all that have seizures. Last year I had one that was to be given 3 minutes after the seizure, but in your guys' case, it's whenever you notice the seizure, at the onset of the seizure. So it's nice that the doctor fills this out for me. Sometimes they don't. And in that case, I make an emergency action plan, which is basically off the doctor's orders, whatever the doctor orders say. I'm going to try to pull up a form from the CDC about head injuries that I use. Our office staff has this. Okay. So if we ever have a kid with a head injury, like say they hit their head on a pole or on the ground really hard, we want to make sure that they're monitored in the office for at least 30 minutes. And I have a little, let me see where it went. I have this form that I send home with the student, and it's for the staff to fill out. So there's just student information up here, description of the injury, how it occurred, and it gives directions on how to use the list here. We want to use the checklist to monitor the student who comes to the office with a head injury. Students should be monitored for a minimum of 30 minutes. And we're going to check for signs and symptoms when the student first arrives at the office, which would be 0 minutes, again in 15 minutes and 30 minutes. So we'll just go over, if they have any of these signs, you're going to check it off. So students who experience one or more of the signs or symptoms of a concussion after a bump, blow, or jolt to the head should be referred to their healthcare professional for further evaluation for a concussion. For those instances when a parent is coming, we want to take the student to the healthcare professional, observe the student for any new or worsening symptoms right before the student leaves. And we're going to send a copy of this home with the parent when they pick the student up for the doctor to review. So if the student has one or more of these symptoms at any time period, the parent does have to come and pick them up and get this little checklist here to take to the doctor. Now, if the student is perfectly fine and doesn't have any symptoms to check off after 30 minutes, then I still wanted to have the parent called so they're notified that the child did hit their head and that we're sending this form home, because there's danger signs here for the parent to look at or to look for after the child gets home from school for the day. And then you would just sign it and write comment here. Resolution of injury, say the student didn't have any symptoms, they returned to class. So the student had one or more symptoms, they're going to be sent home, and then this would be checked off that they were referred to take their child to the doctor for further evaluation. So I have had quite a few concussions at school, kids are running around, not paying attention to what they're doing. And I always err on the side of caution when it's a head injury, because I actually have had some kids come back and maybe they seem okay, and maybe just one symptom, but then they are diagnosed with a concussion and they have a doctor's note saying that they have certain restrictions, like maybe they can't participate in PE or recess for a week. So it's important that the parent is made aware of the head injury and is given this information so they can follow through. We're just going to go over diabetes briefly, and then we'll be done for the day. And then I think it's tomorrow, our next training, right? Tomorrow's Thursday?
Yes.
So we'll do all the first aid and CPR stuff tomorrow. Yes. It is a video which we'll just watch and put on. And then when you guys come in to see me, you'll get your CPR book, and it'll have your card in there too. That's good for 2 years.
Okay.
I think this is the right PowerPoint. I hope it's the right PowerPoint. Okay. So we do have one student on campus, I think at the junior high. I don't know if she's returning or not. I've reached out to the father a couple times, but he hasn't returned my phone call. She does have a continuous glucose monitor, and these are really neat because they provide the student with a blood sugar every 5 minutes. So they're not constantly having to prick their finger every time they need to check their blood sugar. But if a student, and it does alarm if it goes low, there's certain parameters that are set in there, so it will alarm if their blood sugar goes low. But I notice a lot of times the students may feel their symptoms first before it's actually registering on the meter. So if they do have the meter and it's registering low, I do want to confirm that blood sugar though with a finger stick. So the student should have an extra glucometer up in the office and supplies to prick their finger. We're not going to talk about the artificial pancreas. So facts about type 1 diabetes. In 2015, there was 1.25 million Americans living with type 1 diabetes, and about 200,000 youth less than 20 years old, and more than 1 million adults 20 years and older. There's no known cure for diabetes. It's an autoimmune disease that occurs when the person's pancreas stops producing insulin. Type 1 diabetes develops when insulin-producing pancreatic beta cells are mistakenly destroyed by the body's immune system. So usually when a child is first diagnosed with diabetes, they can have symptoms that, kind of go unnoticed before they are diagnosed. Like they may have to pee a lot, maybe even urinating in the middle of the night on the bed, thirsty a lot. And that's because their blood sugar is really high and nobody knows. And they're hungry. And a lot of times they can lose weight too. So when they are first diagnosed, they usually go through a little honeymoon period where they still have some of those beta cells that are still functioning and producing insulin in the pancreas. So I've seen where it's generally maybe about a year or so where those cells, some of them will still be working before they're totally died off. So they're at that point, they usually have a lower amount of insulin that is being prescribed for them for the food that they're eating. And it's easier for them to have a low as well because their body can still be making some insulin, and yet they're also getting the insulin injection on top of that for the carbs that they're eating. So it's important that the child knows what their symptoms are for having a low. And the most popular brand of the continuous glucose monitor is the Dexcom. I'm sure you guys have seen commercials before on TV for it. And that it also has the Dexcom will have where you can put an app on the smartphone will go to the phone so the child can see their blood sugar, and then it can be sent to the parents too in real time so they can see if something's going on with their kid while they're at school. So hypoglycemia, that's what we really have to worry about with our diabetics. It's where the emergencies come in, and that is low blood sugar. It is sudden in onset and can progress to unconsciousness if left untreated. It can result in brain damage or death, and it is the greatest immediate danger. It impairs their cognition and their motor function. Early recognition and intervention can prevent an emergency. So that's why it's really good for the student to be able to be aware of their hypoglycemic symptoms. Possible causes are if they got too much insulin for the food they ate, they ate too little food, or they took their insulin too early and their meal or snack was given too late. They should be eating within 10 minutes of taking insulin. If they had a lot of physical activity that day at PE, if they're ill, or certain medications can interfere. Signs of hypoglycemia: hunger, shakiness, weakness, paleness. They can have blurry vision, sweating, change in behavior. They can become very confused, restlessness. They're just not making sense. And of course, when it gets really severe, it leads to unconsciousness and a seizure. Treatment for the low blood sugar is we want to intervene promptly, check the blood sugar, and we're going to follow the child's diabetic medical management plan. We're going to give 15 grams of fast-acting carbohydrate, which is usually a juice box. I always have my diabetics keep a supply of juices and snacks in the school office. We want to observe a student at all times and never leave them alone while their blood sugar is low. Even if we're treating them for, say they come in, they're complaining that they have a headache and they don't feel right, we check their blood sugar, say it's 70, which is at the point where it's usually considered low and time to treat it. We give them a juice. At that point, we want to stay with the student even while they're drinking the juice. We don't want to leave them unattended because they could pass out. So after they have that fast-acting carbohydrate juice sugar source, we're going to recheck their blood sugar in 15 minutes. If the blood sugar is still below their target zone, we're going to retreat with another fast-acting carbohydrate and recheck the blood sugar in 15 minutes. If the blood sugar doesn't increase to the target zone after 3 treatments of the fast-acting carb, we're going to call the parent and the school nurse. And if you're wondering what the target zone is, it will be specified in their medical management plan, what their low is and what to do. So if a student is experiencing the severe hypoglycemia, that means if they're unconscious or a seizure occurs, we don't want to give anything by mouth. So we're not going to be trying to give them a juice at that point or a glucose tab. We're going to place them on their side, lift their chin to open the airway, and then they have what's called glucagon medication. That's to be given per their doctor's orders. The glucagon is given just like insulin, and it's given in either like the or the abdomen where we give insulin, and then 911 would have to be called, and of course the parent. The student should respond within 10 to 20 minutes, and we're going to remain with the student until help arrives. So if there's ever a situation like this, of course we're going to be calling 911. And glucagon is kind of tricky. It's not that easy to give. Or I shouldn't say to give, to draw up. It isn't an injection. And I have a video on YouTube. I think I can show you guys on how to give it. And then when you come in, I can show you what the actual medication looks like. I'm hearing now from some parents though, that they're giving it via a nasal spray instead of the injection, which would be a lot easier to administer versus having to draw it up and give it by injection. So students with diabetes, they can have the opposite of low blood sugar, which is hyperglycemia, high blood sugar. And that's when there's too much sugar in the blood, but not enough in the cells. So when a student has diabetes and they don't have enough insulin, that insulin is the key to get the sugar into the cells. And when they don't have that insulin, the blood sugar is just it's circulating in their blood and not going into their cells where they need it for energy. So that is usually slow to develop. It's due to insufficient insulin, and it can lead to something called diabetic ketoacidosis if it's not treated. It also interferes with the student's ability to learn and participate. Severe complications can develop when blood glucose remain at above target zones over time and are reoccurring. So if the student constantly has high blood sugars, over the long run, it's going to cause damage to their bodies. It can cause vision problems, heart problems. It damages the small blood vessels. And that's why diabetic people have to be really careful when they get a cut or something, because they can get infections easily with the high blood sugar, and their wounds are very slow to heal, especially if it's a place like on the lower extremities, like the toes or the feet. The blood supply there isn't as good as other places, and that's when you can see if it's left untreated, they may need to have a part amputated. So possible hyperglycemia causes are late, missed, or too little insulin. If the insulin they used was expired, if they took in too much food and not enough insulin, or if they ate and just didn't take any insulin at all, if they had less physical activity than normal, if they have an illness or injury, and stress. If I have a student that's having an elevated blood sugar level, I always want to see if maybe they're not feeling good that day, because infection's a big thing, illness that can spike their blood sugar, and also stress. Also causes are hormones, like going through puberty, medications, or any combination of the above. Signs of high blood sugar are, like I said, frequent urination, thirst, they just can't drink enough water, blurred vision, their breath may smell fruity, and they can have nausea and vomiting, stomach cramps, and be hungry. So if they have hypoglycemia or high blood sugar, of course, we want to verify with the blood glucose check by having them check their finger stick. And then the orders, this isn't really for you guys to worry about, but they usually come with, the parent brings what's called ketone sticks, and it looks like, you know, what you check if you had a pool, the pool chemicals with, or when you go into the doctor's office, maybe they're checking you for a UTI, and they dip it with the little stick.
Oh yeah.
So whenever their blood sugar reaches a certain level, it depends on what their doctor's ordered. Usually they'll want us to check their ketones if their blood sugar is 250 or maybe 300. If it's above that or at that, we have to check their ketones. And then depending on what the ketone level is, they may be allowed to remain in school, or they may have to go home, especially if they're having those symptoms of the stomach cramping and the nausea. Most of the time, the doctor wants them to go home for the day. If they have an insulin pump, which some of our kids do have, especially if they have that continuous glucose monitor, they'll usually have a pump too. And the pump is giving them insulin, it's called like a basal rate. So they're constantly getting insulin every hour, a certain amount. And then when they intake food, we input how many carbs they're eating, and then it'll give them extra insulin for the food that they're intaking. So sometimes if that insulin pump site is bad, and their kid's not getting the insulin, so their blood sugar may be high. Their site is supposed to be changed every, I want to say 5 days or so. So if the site went bad, they're not getting the insulin they need. And if that's the case, if they do have a high blood sugar, we want to give them treatment for the high blood sugar, allow them to use the restroom, access to water, and we're going to give them the correct amount of insulin per the doctor's orders. They'll have a sliding scale for insulin. If the blood sugar is between this much and this much, give them this many units. And then we're going to recheck the blood sugar again to see if the blood sugars come down, and then call the parents as well. So this is just stuff for school. Of course, students that are either having high or low blood sugars, they can't concentrate well. So they may not do well on their assignments. During academic testing, students should check their blood sugar before they take a test to make sure it's stable. Have access to food, drink, and a restroom. And any food and drink consumption needs insulin coverage. If a serious high or low sugar occurs, students should be excused from test and allowed to retake it. And this is just a little example of what a diabetic care plan can look like. I'll keep going here. So this shows what their current medication is, that they give 1 unit of insulin for every 10 grams of carb they're intaking. Everybody's a little bit different. And then they would get that 30 minutes before lunch daily and as needed. And it talks about them having their Dexcom. And our kids with diabetes too, they're supposed to be having, if they're participating in physical activity that day, their blood sugar needs to be checked before PE, because the doctor will write orders on there for what their blood sugar needs to be in order to participate in PE. And if it's below a certain number, what to do. Like give them a snack. And then this is kind of what I talked about earlier. If they are having a high blood sugar, what their correction dose is for insulin, and what I would be giving them for their correction dose if their blood sugar is out of that normal range and it's too high. And this is what an emergency plan can look like. If you see loss of consciousness, we're going to call or designate someone to call 911, the nurse, the principal, and the parent. And we're going to give administer the glucagon as orders and stay with the student. We're not going to give them anything by mouth. So the seizure and that is an emergency. If we see any of these things, which could be signs of a low blood sugar, we're going to do this. Someone is assist a student to the health office. The student's having a low, I never want them walking up to the office by themselves because they could pass out on the way. I'm going to check the blood sugar manually. If less than 70, we're going to give the 4 ounces of juice. And then we're going to recheck the blood sugar in 15 minutes and see if it comes up. We're allowed to, usually the doctors will allow us to do that 3 times. And by 3 times, if it still doesn't get above 70 or greater, then we would have to call the parent to pick up the student. So high blood sugar we talked about, if they have any of these symptoms, thirst and frequent urination, nausea, vomiting, fatigue, sleepiness, blurred vision, headache. We again want to check their blood sugar manually, let them have water, check their ketones, give the correction dose of insulin as ordered, retest and inform the parents. So that's what that looks like. And this just talks about the school nurse's role in the school for diabetics, other people with health problems. And the California School Nurses Organization really does not want other people other than a licensed healthcare professional to be giving a student insulin. So it would either be, as far as insulin goes, it would be myself or Lori, the other school nurse, or one of the LVNs helping a student if they needed insulin. But you guys can definitely help a child, like identify if their blood sugar is low by having them check it and going say, oh yeah, it's 70. Look at the doctor's orders. They need a juice, and then recheck their blood sugar. So that's it. I think, let me see. You have your hand raised.
So what happens if none of the nurses are available at the school sites, like hypothetically?
And they're having a high blood sugar or a low blood sugar?
If they need to have insulin, if they need to have insulin administered. What would happen?
Then at that point, if we were all out sick or something like that, or
so something like that,
Okay, if the secretary should be able to get a hold of one of us for some reason, if they can't, the parent would have to be notified. Before in the past, I've been the only nurse on campus between all 4 schools. I never have had help up until really this school year. So I was managing the diabetics by myself. And I know if I knew that I was going to be out sick or an emergency happened, I would make sure the secretaries knew that morning so they can inform the parent, hey, you're going to have to come do your child's diabetic care today unless you want to keep them home because the school nurse isn't on campus. But There is, just on BE campus alone, there's myself and Lori, and then we have a LVN as well named Lisa. And then at the junior high, there's another LVN. So there's really 4 of us here that should be able to handle the situation. I hope not all 4 of us are out on the same day, but you never know.
Yeah,
in that case,
because when I went to school, it was like only like 1 nurse practically for like the whole district. And like you just said, like you're managing all the schools until recently. So that's why I only ask.
Yeah, no, I mean, it is a definite, it's happened to me before, and the parents had to come to the school and had to take care of their child because maybe it was, and needing insulin isn't really an emergency. It's when their blood sugar drops that it's a real emergency. And if it's like, say the student just comes in the office because, you know, it's lunchtime or whatever, something like that can wait until they get a hold of one of the nurses or the parent. They don't necessarily have to eat at that time. But if the child's blood sugar is a low, anybody should be able to follow the orders and say, hey, this child, the doctor wrote on the orders, if the student's blood sugar is 70 or below, they have to get treated with a fast acting glucose. So let me get them a juice and I'll recheck it in 15 minutes. But giving insulin is never really an emergency. It's really that low blood sugar. Insulin, I mean, if they have high blood sugar, it can cause problems, especially in the long run for their health. But usually if their blood sugar is like 300 or something like that, I mean, if it's like that for a little while, it's not a big deal.
Oh, okay. It's just the low blood sugar that we have to worry about.
Yeah. So when you guys, I will see you tomorrow at 9. I hope the Zoom link I sent out for tomorrow will work. What I'm going to have you guys do you mind just emailing me your phone numbers in case there's a problem tomorrow with the Zoom link so I can just call you? Will that work?
Mm-hmm.
Okay, so email me your phone numbers and then I will email you my cell phone number too, in case you're having problems logging on tomorrow morning. Just text me. If I need to, we can just, I can set up a whole new Zoom link and share it again. Okay. Mm-hmm. All right, ladies, unless you have any other questions, you're done for the day with me.
Well, I was going to ask if I can get the PowerPoints emailed.
Oh, yeah, of course. I'll email them to you guys both, okay?
Okay.
Things are gonna attach it. I was like, wait, okay, maybe we should do it.
And yeah, I'll email them to you. And then when you come in to see me, I hope to have a hard copy to give to you too. Okay?
Okay.
All right, ladies, I'll see you tomorrow at 9.
Okay, and then I just sent you my phone number.
Okay, thank you.
No problem.